I'm so excited to introduce our next presenter, Kirsten Trudeau. Kirsten is a family nurse practitioner focusing on infectious disease research, infection prevention, and simulation-based education. She also serves as a sub-investigator at the Norton Infectious Disease Institute. As an APP research nurse specialist at the Kentucky Infection Prevention Training Center, she creates hands-on simulations and develops educational content to enhance healthcare professionals' infection prevention practices. With extensive experience in pediatrics and adult care, Kirsten is passionate about educating healthcare professionals, bridging research and clinical practice, and driving quality improvement to improve patient safety and reduce infection risk. At this time, I'll stop sharing my screen and welcome Kirsten.
All right, so thank you all for being here today. So I'm going to talk to you all about a topic that's not often discussed in the infection prevention space, but one that is really vital to reducing infection risks and improving patient outcomes. So for the next hour that we're here, we're going to address social determinants of health as a means to reduce infection risks. So of course, funding for this presentation was provided for the Kentucky Department for Public Health. The content includes discussion of unlabeled use of products, have no financial interests or other relationships with manufacturers of products, and no commercial support was provided for this educational activity. So by the end of this presentation, you will be able to define social determinants of health, or SDOH, analyze the relationships between specific SDOH factors and increase susceptibility to infectious diseases, evaluate different SDOH screening tools and highlighting challenges with lack of standardization, apply best practices for integrating SDOH screening into infection prevention efforts, and then utilize SDOH screenings in case-based infection scenarios. So what are social determinants of health? If anybody wants to drop some in the chat, in the comments on what they think social determinants of health are, you can do so now. Education level means financial, yeah? Yeah? Yeah, so really, social determinants of health are factors which affect our health outcomes, which are not medically related. So I see a lot of good answers in the chat. So these are conditions in which people are born, live, grow. These are things that are shaping their daily life. So some of those include the things we're seeing in the chat. Some of the forces and systems around that include economics, politics, societal norms, policies, and all of these can really influence our health outcomes, really for better or for worse, depending on where you're at with those social determinants. So when did we start linking social determinants of health to health outcomes? So really discussions started as early as the 19th century. And as the first real study was in 1967, and it was a study on British civil servants. This was the UK Whitehall study, and it was really looking at mortality when comparing levels of employment. So really what they found was the lower the level of the employment, the higher the mortality rate. And then Whitehall 2 was a follow-up study that was from 1985 to 1988. And it showed the persistence of socioeconomical differences impacting health differently over the 20-year span between the studies. And then in 1985, the Task Force on Black and Minority Health released their first report on minority health in America. And then about 10 years later, in 1995, Savan et al. Launched a study in India, which found that socioeconomic disparity led to a shorter life expectancy. And then in 1999, there was a book released entitled Social Determinants of Health by Michael Mormont and Richard Wilkinson. And then in 2007, the World Health Organization released a report from the WHO Global Commission on social determinants of health. And then in 2010, the World Health Organization dove a little deeper into social determinants and release the conceptual framework for action on the social determinants of health. And then all the way 12 years later in 2022, CMS actually added advancing health equity to its objectives for 2030. And so we need to spend a little bit more time on what categories the SDOHs fall into. So Healthy People 2030 is a part of the Office of Disease Prevention and Health Promotion. And this Healthy People initiative has been around for over 4 decades. And they work on identifying public health needs within communities and organizations and individuals in the US. And they make them priorities for an overall goal to improve health and well-being. So the 5 categories for Healthy People 2030, you can see here, they focus for social determinants of health, they're focusing on education, access and quality, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. So for education, access, and quality, higher levels of education are linked to healthier, longer lives. So a goal of Healthy People 2030 is to increase educational opportunities and help children and adolescents do well in school. For healthcare and quality, about 10% of Americans do not have health insurance, making them less likely to receive their primary care, those preventative screenings, and then, of course, medications that they might need. So the goal for Healthy People 2030 here is really to increase the access to comprehensive, high-quality healthcare services. And then for neighborhood and built environment, when we have folks that are living in neighborhoods with high rates of violence, where there is crime, where there's environmental safety issues like poor air and water quality, all of those really affect our health and well-being. So the goal here is to create neighborhoods and environments that promote health and safety. And then from some social and community context, positive relationships we know can reduce the negative impacts of challenges that people face, particularly related to their health. So the goal here is really to increase social and community support. And in economic stability, it may or not, it seems staggering, but it's true that about 10% of the United States lives in poverty. And so that makes it really difficult for those to obtain food, healthcare, stable shelter. And so steady employment can improve these challenges. So the goal here is really to help people earn steady incomes that allow them to meet their health needs. And so as far as health-related social needs go, the terms between health-related social needs and SDOH are often used interchangeably, but the CDC really puts emphasis on social determinants of health, looking at the population picture, while the health-related social needs really focuses more on the individual level. So you'll often see more of the HRSN more when discussing like tools and screenings, and then social determinants of health, more of the population view. But for the purpose of this, just to understand what the health-related social needs are, per the Department of Health and Human Services, these are health-related social needs or social and economic needs that individuals experience that affect their ability to maintain their health and well-being. And these include needs such as employment, affordable and stable housing, healthy food, personal safety, transportation, and affordable utilities. So you can see that there's a lot of overlap between these and social determinants of health, which is why these terms are often used interchangeably. But we're really going to look at it more from a population picture for social determinants of health. So for Healthy People 2030, their current work. So who's currently working with them within this initiative? So the Social Determinants of Health Work Group includes experts in fields related to social determinants of health. So they have experts from the Office of Disease Prevention and Health Promotion, from the National Institute of Health or the NIH. They have them from the CDC, the FDA, the Health Resources and Services Administration, and the National Center for Health Statistics. And really their goal is to focus on health equity, health disparities, economics, and finding those populations who are vulnerable. And currently they have 8 objectives which they have defined, which they are currently tracking, monitoring, and have objective statuses listed for all of them. So if you look at the 8 objectives from the the work group objectives, you'll see here that this is directly from their website. So you can see that they list each of the objectives, and then they tell you if they're improving, if there's no change, if they're getting worse, or if it's something that they are still currently collecting data on to get kind of a baseline. So the first objective is to reduce the proportion of people living in poverty, and that is improving. Next is to increase employment in working age people, and this is also improving, and it is a leading health indicator. We'll talk about that a little bit more on the next slide. And the next is to increase the proportion of children living with at least one parent who works full-time. This is also improving. Next is to reduce the proportion of children with a parent or guardian who has served time in jail or prison. This is improving. Reduce the proportion of families that spend more than 30% of their income on housing. There is little to no detectable change here. Increasing the proportion of high school graduates who attend college the October after graduating. This is actually getting worse. And then increase the proportion of voting age citizens who vote. This is also getting worse. And to increase the proportion of federal data sources, which include country of birth. This is a research objective. So you can see here that while there are several that are improving, there are some that have no change and are getting worse. So there is quite a bit of work still to be done. So just pulling one out, I pulled out this leading health indicators so that you could see kind of the more granular data with it. So within these objectives, you can go in and you can see the baseline, the most recent, and then the target goal for each of the objectives to understand where they're getting those numbers of improving, not changing or worsening. And so this is a leading health indicator to increase employment in working age people. So the baseline in 2018 was 70.6, and the most recent data showed improvements to 71.5, and their target goal is 75%. So you can see that they're going in the direction that they desire. It's just kind of a slow uptick. So what does the data show? So now that we have an idea of social determinants of health, what does the data show demographically to correlate to social determinants of health? So I got this information from the American Community Survey, or the ACS, and it shows prevalence of 9 key measures using the Places social determinants of health data capture. So you might be surprised to hear some of these statistics. So 7.9% of households in America are without broadband internet. There is crowding in 3.5% of occupied housing. About 40.6 million people make less than $75,000 a year and spend more than 30% of that income on housing. Of adults who are over age 25, 10.2% of them do not have a high school diploma or equivalent. And then a staggering 65 million people are living 150% below the poverty level. And then persons identifying as racial and ethnic minorities make up 42.9% of the population. And you'll see as we get further into social determinants of health why that is important. And then 7.8 million households are single parent households. And you can already tell from those objectives that we saw on the previous slide that single parent situations definitely increase your social determinants of health risk. And then in September 2024, the unemployment rate was 4.1%. So just to get an understanding of what it means to be living 150% below the poverty level, I've highlighted the column here. So 100%, 50% below the poverty level is this income for your household size. So you can imagine that poverty can make it really difficult to purchase, just basic needs on this level of income, let alone expensive medications, a car to get to appointments, even affording a bus pass to get, or taking a cab to an appointment. All of that would be very difficult when they're struggling to just meet their very basic needs of food and shelter. So this is a look at the Census Bureau data from Kentucky. You can find this on every state. I know we have a wide representation of states here, which is amazing. You can find Census Bureau data from your state. But looking at this specifically for Kentucky, you can see that Kentucky has a population of 4.5 million people with an employment rate of 57.4%. The median household income is about 61,000. And 27.8% of people have a bachelor's degree. 5.4% are living without health insurance. And nearly 208,000 identify as Hispanic or Latino of any race. So as we go through this presentation, think about how these factors could tie into infection risk in the patients that you care for and what the demographics look like where you practice. So after the last slide, you might be thinking, you know, that's great. Like you have all this data and it's on a website. And how am I supposed to know what my patients are going through when that is just data from a state level? And I think the answer to that is tricky because we're still trying to find out how to collect data, social determinants of health data. But I did put this slide in here to help understand what the social vulnerability index is, to give you a better idea of the patients in your area, you might find some value in this index. It was really developed out of a public health need, like for preparedness and understanding social vulnerabilities and how those might impact responses after like human-caused hazards or public health emergencies. So the social vulnerability index really helps to identify at-risk communities who might need assistance in relationships to those disasters, whether it's pre, post, or during. And it does include 16 of the U.S. Census variables. So it doesn't directly fall into social determinants of health, but it does provide a really nice visual, I think, and a really good data resource for at-risk communities, really at more of a granular level for you to see than just a national or state level. But you really can't make assumptions about everyone in your area that they will fall into this level of vulnerability. To get the true detail, you of course really just have to talk to your patients and you have to ask the questions and understand where they're coming from. So we'll get more into that soon, but I did want to put this out there as a resource because this is available state by state too. And you can just see the level of vulnerability from socioeconomic, household, racial and ethnic, and the minority status, and then housing type and transportation. And I just think it's very interesting to see that from a county level so you could hone in a little bit further on where you live and work. So let's add another layer here. When we're talking about social determinants of health, there are many parts of medicine which social determinants of health can impact. So you're probably aware of the primary care impacts, the pediatric impacts, mother and baby. And for us in infectious disease and infection prevention, this is sort of a newer space where people are really starting to talk about this. So the list really goes on, but I'm going to ask you guys here to put in the chat what social determinants of health you think might be examples of affecting someone's infection risk. Overcrowded living conditions, yeah. Can't afford the medicines. They have an antibiotic. Yep. Lack of access. Finance. Yes. Yes. Yes, you guys are hitting the nail on the head here. Okay. So limited personal health literacy leads to worse health outcomes, and employment can affect health outcomes. Like if they don't have paid sick leave, they're more likely to come to work when they're ill. And then, of course, increase the risk of transmission to the people around them. Housing instability. I saw overcrowding was one of the answers on there. Housing quality. So overcrowding can increase the risk of infectious disease, damage in the home if there's exposed nails or broken appliances, if they're, stepping on exposed nails, if they're not cooking their food adequately because they don't have a stove. Those are all things that can increase our infection risk. Language. I see they don't understand how to take their medications. Yes, What if it's a language barrier? It makes it difficult for patients to understand. It has been shown to decrease the quality of care given. Medical insurance, which is less than adequate, leads to disparities in health, and often uninsured children often miss those immunizations and well-child visits that are so important to their care. Lack of transportation, I saw that as an answer. It can lead to more severe illness. We saw this with COVID-19. Lack of primary care means they're less likely to receive that preventative care. Poor environmental conditions, so that would be poor water, air, noise, climate changes or hazards in their environment. All of those can have an impact on their health. And incarceration increases the risk of infectious disease and other medical conditions as well. So as the IP, you might be thinking, where do I fit in? So can we think of some ways that IPs might be able to assist with social determinants of health and decrease infection risks? So again, I'll ask you if you have any ideas, throw those in the chat. If there's something you're doing at your facility, I'd love to hear about it. And as we go through this presentation, keep thinking about ways that you can assist with this process, and then we'll review all of this at the end and go over it. Community education, vaccination, education. Love it. All right. So let's look at some historical examples of the impacts of social determinants of health and infectious diseases. And we'll start with the decline of TB in Western societies, comparing Europe and North America in the late 19th to early 20th century. So there was a Western decline of tuberculosis before medical therapies. Why is that? So housing improvements, and there was less crowding. There was changes to improve nutrition and living conditions. And then the process of pasteurization also improved infection risks as well. So these are all very interesting things to think about in terms of social determinants of health, especially in a situation before there was a medical therapy for such a deadly disease. So if you think about that as we move forward and talk about more current things, you'll see some of the same trends. So I pulled some articles just for us to see how some of these can affect, these social determinants of health can affect different disease processes. So the first one here, we'll talk about RSV. So this was the first one was a literature review of 20 studies to determine if children under the age of 5 were at a higher risk for severe RSV when living in crowded home conditions. And the results of this did show overcrowding increased the risk of lab-confirmed RSV in high-risk infants and children under the age of 5. And then the second one here was a study that looked at the RSV surveillance of adult hospitalized RSV positive patients, both actively from 2016 to 2018. And then they even looked retrospectively from 2014 to 2015. And the incidence was calculated looking at census tracts for poverty and crowding. And the data included 6 states and 33 counties. There were over 1,700 cases reviewed, and RSV hospitalization was correlated to increased census tract level for poverty and crowding. Methicillin-resistant Staphylococcus aureus, or MRSA. So this was a review article from Tong et al., and it was on the global implications of the emergence of community-associated MRSA in indigenous populations. And the authors here focused on MRSA in Australian Aborigines communities and looked at the social disadvantages which make them more susceptible to MRSA. And this community has been dealing with MRSA since the early 1980s, and various strains of MRSA have been identified. But what makes the indigenous population more at risk? And that's what they were looking at. So after studying this group, they often lived in isolated or remote areas, making it more difficult for them to get to appointments. They have risk factors that included crowding where they live, poor hygiene. In this case, they were all using a communal sauna, poor washing facilities, even deficient water supplies, which of course would increase your infection risk when you can't wash your hands and do all the other things to have good hygiene. Some studies have found that these communities are so crowded that they have about 3 to 7 people per bedroom. And there's also some concern for dog overcrowding, which is another potential risk factor for MRSA, given that there are about 3 dogs per household, and it's not uncommon for those dogs to have wounds. So, of course, the water problems make hygiene and laundering clothes more difficult. So all of these factors are noted, as well as increased risks increased risk for MRSA, as well as increased risk for scabies and impetigo in the same communities. And then we have COVID-19. So this was a study that used data from Understanding America Studies, Understanding Coronavirus in America Survey. And it was used to determine if social determinants of health explain racial and ethnic disparities in the COVID-19 infection. So as we saw in the COVID-19 pandemic, Hispanic people had a greater incidence of COVID-19, and some key social factors were identified to putting these people more at risk. They included like working away from home, having lower educational attainment, higher numbers of cohabitants in the same home. So again, that overcrowding. And additionally, the study found structural racism goes beyond these social factors. So nonetheless, minority groups continue to be affected disproportionately by COVID-19. And HIV. So this article focuses on being caught in a syndemic of those infected with HIV. So a syndemic is an interplay of health and social issues like homelessness and food insecurity. So this article notes research findings that unstable housing among HIV positive patients are at higher likelihood to have higher viral loads and suffer from non-adherence or failure to access resources medically and socially. They experience issues with substance abuse, have mental health issues, particularly depression, and then they have higher rates of mortality. So these findings came out of data from Canada, but both Canada and the US show data supporting that those who are food insecure are less likely to achieve a viral load, which is undetectable, which of course is our goal when we have these patients on antiretroviral therapy. They have an overall poorer mental health and physical health, which of course leads them to higher levels of morbidity and mortality. So what are we going to do about it? We know it's a problem. We know people are talking about it. We know people are setting goals, implementing interventions, and monitoring data. But what are the healthcare workers and the infection preventionists actually providing care in the hospital going to do about the situation? So it's a really tough question. And I think here is where the ease of simply saying, let's ask the patients turns into questions where there's a lot of problems implementing that standard process. So the ideal process here would be to screen patients for social determinants of health, refer them to the appropriate resources, and then follow up with them. The reality of what's actually happening is there are breaks in that ideal process. There are difficulties implementing screening tools as far as facilitators, barriers, systematic uptake of implementing those processes, and then referrals. They might be missed. Maybe the patient refuses them. What about the bandwidth of social services? If we're putting more on them when they are already pushed to their limits, can they handle it? I don't know that we have the answer for that. But for screening for social determinants of health, I think you get into a lot of questions when you ask an organization to start doing this. So if you're going to implement social determinants of health screening at your facility, what questions might you have? What do you do with that information? What tool are you going to use to screen? Who is asking the question? And who's answering the question? So are you, as the provider, asking the patient, or is the patient filling out the information on their own? Is a family member filling out the patient's information for them? Or is there a process that's standardized across your organization? Is it the same for outpatient as it is inpatient? Is it the same for pediatrics versus adults? Is it the same for rehab versus, an acute care? And then one of the biggest questions is, how do you decrease the stigma and discomfort to ensure the answers are true and accurate? And I saw in the beginning of the presentation when I asked you all to put things into chat, someone said stigma, and that is so true. There is a big concern for stigma, and we'll talk a little bit more about that. So when you are looking to start screening for social determinants of health, you'll find a plethora of screening tools, but there is not one screening tool that has been considered the tool that everyone should use. There is no guideline that says this is the tool that you should be screening with. People are either using these tools, they're developing a tool of their own, which can make things difficult in the long run when looking at the data that's being collected. But nonetheless, I included this review article, which reviewed the tools that were available in the US to screen for social determinants of health. This was back in 2020, so I can only assume that there are many more tools available now. But this is really one that's considered one of the best review articles. And it shows that there's not, even 5 years later, there's still not a standard tool, even after we've reviewed these different ones that are available. So looking at this list of tools, you'll see most commonly assessed was exposure to violence, unemployment, food security, housing, and education. Often domains that were missed include legal stability, moving, transients, social support, and multi-level assessment. And on another note, many of these tools failed to ask about the length or the duration of the condition. Is it temporary or is it chronic? And I think that's a really important key factor to understand the amount of time that someone has been dealing with this. Another measurement challenge lies in the absence of scoring tools and a lack of consideration for combinations or patterns of responses. And how do you explain this? There are no tools to address multi-level influence like a community or neighborhood factor. So what came of this review article? So we know that standardization of what is required related to social determinants of health data need to be collected, and we need to place focus on those missing domains. And we need to address, the screening should address duration. Screening tools should be scored and quantifiable to allow prioritization and ability to implement interventions. Oftentimes, I think back to Rochelle's presentation on performance, process and performance improvement. One of the big Six Sigma dig to make things is don't boil the ocean. Well, with social determinants of health, when you start to see these screening tools, you can very quickly see that you want to help someone, but you're going to end up boiling the ocean in many cases because some of these screening tools are so cumbersome. So if you quantify them, it allows for prioritization and helps you implement interventions in an order of which it can help the patients in the best way, in the fastest way, and then you can approach the lower priority issues as you move forward. And then institutions and practitioners should be assessing for these health-related these social determinants of health systematically. And then Dr. Alicia Cohen in this article pointed out that we know that there's a relationship between health and unmet health needs. When help is offered for the unmet need or problem, most choose to accept it, and over half of the concerns are addressed. So there should be some policy and research needs. So data from post-screening implementation is needed to determine the value added. We need data on uptake of the referrals and services, but it would also be good to have some guidance from different agencies on funding or regulatory bodies on outcome measurements related to these screenings and interventions. And that is something we're starting to see, but just not as quickly as we would like to see it. And this is where the Centers for Medicare and Medicaid Services come in, or CMS. They are committed to improving health equity and making efforts to screen for social determinants of health. As such, they've created a tool, the Accountability Health Communities Health-Related Social Needs Screening Tool, which they have implemented with community partners across the U.S. to see how this implementation would work. So this tool addresses many different categories, as you can see here. There are 26 questions on this screening tool, so you must consider how long it would take to go through this screening tool and really address all of the answers provided by the patient. And so I did put in screenshots of the tool so that we can really see, one, how thorough the tool is, but two, how much effort it would take to implement this tool While it is the right thing to do and it is the most effective thing to do, you really have to think logistically about who is going to ask these questions and what are they going to do with this information. So you can see here that with this particular tool, they do address health-related social needs or the social determinants of health of concern. They also address the duration of that, which, as we talked about, was part of a missing piece that not all of the other ones back in 2020 did. So for living situation, what is your living situation? What are the problems with that living situation? For food, in the past 12 months, so they're quantifying the time. Are you worried that you would run out of food before you get more money? And it's asking, is this always a problem? Is it sometimes true? Is it never true? Transportation in the past 12 months, again, quantifying. Have you had a lack of reliable transportation that affects getting to your medical appointments, meetings, work? Utilities. So in the past 12 months, have they have their utilities shut off? If it's yes, no, or already shut off, that's important to know. Safety. What about the area that the people that they're around in the area that they live? How often does someone physically hurt you? That's a really important question. And who are you asking? When you're asking that question, are you asking their family to leave? Because oftentimes people get complacent and they start asking these questions, and the person who's hurting them might be right in the room with them. So, it goes down to, verbal and emotional abuse, financial strains. How hard is it for you to pay for basic things like food, housing, medical care? If someone has $20 to pay their medical bill or buy some groceries for a few days, they're going to buy their groceries. For employment, do you have trouble finding work or keeping work? For family support, we saw that, not having support from their family, their friends, their community impacts their health outcomes. So we want to know, do they not have any help? Do they have a lot of help? We need to know that. Do they feel isolated or lonely from others? Education, do they speak in a language other than English? Do they have formal school training? Do they have a high school diploma? That's going to help us understand what literacy level we're working with when we're trying to educate these patients. Physical activity in the last 30 days. How often did they engage in activity and how many minutes did they spend doing so? Substance abuse, asking about in the last 12 months, they're quantifying the number of drinks, they're quantifying the number of tobacco products. In the past year, talking about prescription drugs for non-medical reasons. How many times have you used illegal drugs? And over the past 2 weeks, have you been bothered? This goes into their mental health. Is this a depression issue? Are they feeling down, depressed, or hopeless? And then, of course, disabilities. Is there a disability that's making it difficult for them to concentrate, remember, or make decisions? Do they have difficulties running errands or visiting a doctor's office when they're alone? So you can see that is a very, very lengthy list. And there's just lots of questions that come about it because you don't know who's going to ask the questions. And if someone is asking the questions, is there a fear of stigma of saying the wrong answer? Are you going to contact Child Protective Services if someone doesn't have electric in their home? So there's a lot of issues when it comes to implementing this. So what are the requirements? So when it comes to screening, there really aren't any mandates from regulatory bodies just yet. According to CMS, the use of this screening tool is not standard practice or required across the U.S. It's only standard practice in the accountable healthcare communities, so the partners that you can see on this map at this time, because they are still collecting data. So concerns with barriers and social determinants of health. When you're screening, the concerns of barriers and stigma, when you're addressing these with patients, they often have fear of repercussions. That stigma that we talked about, They have fear of child protective service involvements. It is less likely that mothers will seek care for both herself and her child out of fear for those repercussions. So this is why the way we ask the questions and who asks them and how they receive the information truly does matter. And no one's going to divulge sensitive information about themselves or their situation without you first establishing a level of trust. So on that note, who does ask these questions and how? So when comparing the two, one study showed that there is a preference towards self-reported electronically answered questions, and this was per a systematic review from Merity et al. In 2020. Another study looked at electronic self-report, specifically EHR portals, and found that those who responded had the most access to resources in their neighborhoods. They had private insurance and mostly identified as white. So the results showed that those less likely to respond were more likely to have a need, and they called this a non-response bias. So it could possibly be due to digital inequities, which is very possible. So this really begs the question, how can you get the most honest answers and provide the most assistance? Well, you have to build trust, and regardless of how the questions are distributed, that will be an organizational decision. You can follow up with a conversation and establish trust and open communication with that patient. This can allow you to dig a little bit deeper to the root cause of what that need is. And we'll soon discuss Z codes, which I think will be beneficial when you're starting to collect this data. But the biggest thing is you need to form the trust and the empathy to get honest answers. And so what should happen after screening? There should be a follow-up to social services that are rendered, clinical community linkage. So what resources are available and do they know their options? Take time, sit down and listen once they have your attention and educate them. And then when making their referrals, make it important to the person. So if you're trying to educate them on how to ensure that their PICC line that they're going home with stays clean and they have a decreased risk for infection, who to call when there's a problem. When you're educating them on that, don't just give the spiel and not make it important to them. Ask them about their family. You know, your granddaughter really wants you at her birthday party. You said you were really excited about that. Well, let's make sure we keep your PICC line clean until we can get it out of there so you can make it to her birthday party. Those things are really what connects the patient to the significance of what's going on with their body and and helps them feel empowered to keep those infection risks down. So Z codes, what are Z codes? These are codes from the ICD-10. They are from Z55 to Z65, and they're used to document data collected from the social determinants of health screening. So these codes can be used to identify risk factors and connect patients with people and resources like social workers, community health workers, and case managers. So these codes are collected. We use the Z codes to document social determinants of health. And then we'll see on the next slide here that we can dive a little bit deeper into Z codes too. So of all of the Z codes, you can see many codes have subcodes that allow more information to be coded. So for example, if a person says that they have problems with housing, are they unhoused? Do they live in a shelter? Are they housed but it's inadequate? You can dig deeper and document Z codes, and that will give a better scope of the problem that allows for more targeted assistance to meet their needs. And this is really important looking at the population picture that you're working with, because you might see specific Z codes and subcodes that are more prominent in the population that you work with, and you may be able to come up with systematic organizational interventions to help with those social determinants of health. So CMS has a nice document summarizing the use of Z codes. So you'll collect the social determinants of health data during the encounter, document the data, map the data to Z codes, and then use the social determinants of health Z code data and repost the Z code data findings. So as the infection preventionist, you know, I don't think that I wouldn't expect you to be the ones collecting the social determinants of health data. I don't expect you to be the ones documenting it or collecting, looking at these maps. initially. But I do think, and what I hope for the future is that we can use these Z codes to look at data from a population level and understand what our population of patients are going through so we can start to make changes before an infection occurs. So what is your role? So let's recap. We asked ourselves in the beginning of the presentation, where do we fit in? And until recently, very few infection prevention organizations have put a lot of emphasis on the IP roles in infection prevention. But in 2024, APIC released their Impact of Health Disparities and Inequities on Healthcare-Associated Infections, a call to action. It's a white paper, and it very nicely details the relationship of social determinants of health and infections. And so they made these recommendations as calls to action for the IPs to make an impact on social determinants of health. So you want to proactively address social determinants of health. You want to work with multidisciplinary teams to discover barriers, collaborate with community health partners, seek out gaps in patient care and how patients are educated, dedicated resources, utilizing educational toolkits, and forge relationships with community organizations. And so moving forward, you really could consider looking at social determinants of health and how you can implement changes organizationally that would impact the social determinants of health you see most in your patient population. So for example, if you're looking at bundle compliance, you might find lower levels of compliance related to some social determinants of health. And you might be able to find resources to help improve some of those determinants. Now, some of those things are going to be non-modifiable that you have no control over. But I do think that the more Z-code data and population level data that we're able to collect, we might be able to see more of these trends. But just like as an example, if you have a pregnant woman who is going to have a C-section, well, you might see that there is a decreased level of women who do their CHG baths before their scheduled C-section. Well, if the population that you're dealing with, you find a trend of they're not doing it because they don't have transportation to get to the store. They live in a rural area where there is no store that has CHG. They don't have the finances to pay for the CHG because it's super expensive. Then you might implement something at your facility to, hey, let's give them the CHG at their prenatal at their one of their visits before they have their scheduled C-section with easy to understand instructions on what to do and how to use that CHG bath. And then you can improve your compliance and your infection risk related to C-sections if you do something like that. But along with that, those recommendations, it is important to remember the human relationship qualities when it comes to social determinants of health. You really need to build trust, be empathetic, and take time to listen. So we'll go through a quick scenario. We're going to look at this from the perspective of not addressing social determinants of health and addressing social determinants of health. So this is Lola. She's a 22-year-old woman. She arrives at a clinic with symptoms of painful urination. She does not have transportation, so she walked to her appointment. She is not proficient in English, and her primary language is Swahili. So if you want to put in the chat some social determinants of health that you might think would change her pathway of how her care is managed, you can do that now. Transportation and language. Yep. Yep. So for pathway number 1, insurance. Yep. For pathway number 1, she was not screened for social determinants of health. So she gets there and there's no interpreter available. She does her best to explain her symptoms, but the hurried provider offers minimal communication. And we saw that when we said that language barriers have been shown to these people have a decreased quality of care given to them. So this provider is hurried. They offer minimal communication. She is asked to give a urine sample, but is not given instructions for clean catch, which may affect the test accuracy. The provider prescribes antibiotics and tells her they will call in the results. And when they later call, her urine culture shows that the prescribed antibiotic will not effectively treat the infection. So they send a new prescription to her pharmacy. But Lola does not fully understand the call call because they called her and talked to her in English, and not wanting to take the time or, feeling bad, not wanting to ask for clarification. She doesn't. And then she does not have transportation to pick up the new medication, so she doesn't. And then 3 days later, she develops a high fever, severe pain, leading to hospitalization for pyelonephritis or kidney infection. So I don't think that is very far off from some of the scenarios that some of us on this call have maybe seen. So what happens if we do screen for social determinants of health? So she arrives to the clinic, she's screened appropriately. A medical interpreter is arranged through a video service. The provider takes their time to listen to her symptoms, explains the importance of proper urine sample to ensure accurate test results. Recognizing her transportation challenges, the clinic assists by arranging a pharmacy delivery service for her antibiotic and for her urinary tract infection. The clinic follows up with a call on the urine culture results. The interpreter relays the information through a third party on the phone with them, and the new prescription instructions are given in Swahili, ensuring that Lola understands the need for her new medication. The pharmacy delivery service delivers the new prescription. She takes the medication as prescribed and recovers without complication. So you can see that addressing those social determinants of health can have a profound impact on how someone is able to manage their care. So just a scenario here, some of those social determinants of health were lack of access to transportation. Without access to reliable transportation, Lola faced challenges of getting to her medical appointments and the pharmacy. She had language literacy. Her limited English proficiency and lack of interpreter prevented her from fully understanding her diagnosis, the treatment, follow-up instructions, her access to healthcare and quality. The provider was rushed. There was a lack of proper communication, failure to ensure correct sample, which impacted her quality of care. Socioeconomic factors. If she does have financial resource issues or lack of insurance coverage, which we didn't talk about, but if she did, she may hesitate to seek any additional care if her symptoms worsen. And she did not feel empowered to ask questions or seek clarification because of past experiences that she's had within healthcare facilities. And these are just some great resources. We talked about the Healthy People 2030. There's Pathways to Populations Health Equities. This impact of health disparities and inequities on HAI is a call to action. That is the APIC white paper. This is the HC health-related screening needs tool, screening tool. And then a guide to using accountable health communities, health-related screening needs screening tool, promising practices and key insights that goes along with it. Some key takeaways here is social determinants of health impact patient outcomes in many ways, including infection risks. Lack of standardization for screening is challenging when screening for social determinants of health. We want to be proactive and assess for risks before there is a problem, and then take time to listen and understand and build trust. And of course, you can follow us on social media. And that is all I have for you all, and I'll open it up for questions.
There is a comment, real example, worked as part of a team developed to assist an impoverished family with a child with cancer experiencing multiple systemic infections resulting in frequent hospital stays. The apartment building was infested with roaches amongst other needs. So it goes across all spectrums of care for sure.
Absolutely.
Kathy Brooks, I see that your hand is raised. I don't know if you did that on purpose. Did you have a question? If so, you can put it in the chat or the Q&A. So Z codes, is that something everyone is currently using or can be used, just as a clarity?
So I think it depends on what electronic health record you're using and what your ability is to document those Z codes. It is not something that's standard. It's not something that's necessarily required, I don't think at this point. But I do think that it is something that is coming. So as people start to implement their more advanced EHR systems, I do think that we'll start to see more documentation of Z codes once we figure out the standardization of what tool to use, what questions to ask, what data has to be collected. I do think we'll start to see that flow into the EHRs, and I do think we'll start to see Z codes used from that, or collected, and that data being used more appropriately.
Any other questions I see a lot of thank yous and very informative. This is I think this is kind of a new topic for infection prevention. Social determinants of health is clearly not a new topic, but really considering what roles infection preventionists can play in social determinants of health. And, there is the comment, this is a great motivation to think outside of the box, and figure out what are some other opportunities of things that we can do that would meet the same outcomes with maybe different resources or different processes. So